if everybody's ready, I would like to welcome all our speakers, our attendees to the EUPSA Global Pediatric Surgery Initiative webinar. This is our second webinar, and the webinar will be recorded and later on will be broadcasted on our YouTube channel. So we would like to welcome you all. Today, we have two young colleagues, both at the moment studying and practice in Canada, Ayla GERK and Dunya MOGHUL. These two colleagues will give us important insight into academic global pediatric surgery, understanding pathways, experiences, and relevance. So thank you both for accepting our invitation. And I would like to now ask Judith Stolz, who is our Global Pediatric Surgery Initiative cooperators. She will introduce our two colleagues, and then we will be very happy to listen to them. Thank you.
Thank you very much, Gonca. So I'm really happy for everyone to be here today. For all of you, I have met Ayla and Dunya also out of my passion for global pediatric surgery, but only digitally. So I want to present them now, and I'm really looking forward to their talks. So Dr. Dunya MOGHUL is a pediatric surgeon from Afghanistan and a fellow of the Jean-Martin Laberge Fellowship in Global Pediatric Surgery at the Montreal Children's Hospital, where she's also pursuing a PhD in surgical and interventional sciences. Her work focuses on global pediatric surgery with particular emphasis on health equity and expanding access to surgical care for children in low-resource settings. And Dr. Ayla GERK is a physician trained in Argentina, born in the US and raised in Brazil. She's currently pursuing her PhD at McGill University. She conducts her research at the Commissar Lab, based at the Montreal Children's Hospital, and is a research fellow as well at the Jean-Martin Laberge Global Pediatric Surgery Fellowship. Ayla completed the Paul Farmer Global Surgery Fellowship at the Harvard Program of Global Surgery and Social Change, during which she participated in the development of Ecuador's NSOAPs, so the National Surgical Obstetrics Anesthesia Plans. She was recognized in 2024 as one of the 40 under 40 by the Boston Congress of Public Health, and Ayla is an active advocate for equity in global health and also gender equity. So with this, I want to give you the floor and thank you again for joining us and starting this conversation.
Ayla, just a second. I would also like to announce that if there are any questions, you can use our chat or our answering question section, and we'll be more than happy to ask Ayla and Dunya to answer the questions. Thank you.
Thank you. Thank you. I'll share my presentation now. I hope you can see it well. Yes? Okay. So first of all, good morning, good evening, everyone. We're really, really grateful to be here today, sharing something we're really passionate about. And we're thankful for the platform and for the possible future collaborations that we can extend from this opportunity. So I don't want to spend too long in defining global surgery, as this was already shared in previous lectures from what I understood, and many might be already aware of this concept. But since both Dunya and I are sharing how we ended up in this field, I want to briefly ground us in what it means and then tell you a bit about my own path before she shared hers. And it's two different stories, very different backgrounds, but with this shared common goal. Let me continue. So global surgery is an academic and health system discipline. It brings together research, clinical practice, policy, and advocacy with one central aim, which is to strengthen surgical systems and advance health equity. This field emerged from the recognition of the significant gap in access to safe, timely, and affordable surgical anesthesia care worldwide. And this isn't a gap that can be closed through, for instance, short-term clinical workforce. No, it requires data, it requires system thinking, and most of all, long-term, locally driven solutions. So this is really the orientation of global surgery. It's about health systems improvement, not individually, but on a system level. And the focus is on equity, capacity building, and integrating surgical care sustainably in, for instance, national health plans. And I want to stress that global surgery applies not only to LMICs, but in any setting. Global surgery, as its name says, should be global, right? And when we should start thinking on how we can incorporate also this into our own local settings. So another part now transitioning to the pediatric global surgery component. These gaps are just as troubling and in many cases even worse when you talk about children. With so many children growing up in settings with almost no access to surgical care, pediatric global surgery becomes an area where academic work isn't optional but necessary. And that's why we have to study these gaps to understand where systems are failing children and how we can actually improve them.
I think your screen sharing, we're just seeing your first slide. Do you
That's it.
mind sharing it again? I think it has,
Oh, sorry.
because you're advancing slides, as I got the feeling.
Yes. Yes. Okay. Can you see it now?
Now we see
All of the
all
slides.
of them at once.
Oh,
Okay, that's fine. Thank you. Thank you.
okay. So I
No, that's fine. If you
slides
just
you missed. Okay, I'm here now. So, what talking about pediatric global surgery and global surgery in general, and this transition into something that is based on pillars of research, academia, and policy and advocacy. There are many organizations now that have been working towards these shared goals, towards creating sustainable practices. And these are organizations, a few that we have been closely involved or collaborated with, and they're here to share if you're interested. These are great organizations to keep in contact with and follow up and even collaborate with. So what are these pillars that I mentioned that these organizations and we try to put into our practice when we talk about academic pediatric global surgery? Of course, research is a huge component. We can't to expose problems and to understand solutions, we first have to back up on evidence-driven evidence. And these driven evidence are the ones that will motivate us and policy and policymakers to sustain change. And then comes advocacy and policy. And then when we talk about sustainability, it's also understanding, for example, workforce training and how we can build from the ground these changes. So research. Now we're coming to the main component of the talk, right? Which is the academic pediatric global surgery component. But as I mentioned, research goes way beyond. When we talk about academic global surgery, it's trying to expose these issues, but also trying to understand solutions. It's about innovation. It's about clinical practice. And that's where I found myself. I started as a medical student and then mainly as a working on a clinical setting. I saw the frustrations of not being able to deliver the best for my patients and when the system failed them. And that's when I saw that it was not just a clinical practice that would save my patients, but also the social component of it, also the structural component of the hospitals and what we were delivering. And that's when I started being involved more closely with the program Global Surgery and Social Change, which later I did my fellowship there. But I started even as a medical student collaborating with them, and mostly in Team Brazil, which I was raised and grew up on. And that's when we found this community of really highly motivated individuals working towards a shared goal. And through research, we were able to expand on our policy and advocacy practices and create awareness into our community. So these are, for example, a few of the outlets through which a publication, which should not be the end goal to be, okay, I published my paper, but how we can translate this into society, how we can translate this into policymaking. So a few of our papers naturally and sometimes more rigorously went through newsletters and podcasts and media to close this gap on consciousness and awareness. So this brings me to advocacy. So advocacy is a practice in which it should be at all levels. It should be from ground up, but in a bicyclical way. And it should involve all stakeholders. It should involve media, academia, policy, but most of all, also community, individual, patients, and us as practitioners, and being involved together to try to understand from each points and perspectives these gaps and how we can close them. And this is possible. This is an example. This happened last year in Brazil, in which this was a symposium focused on a rare disease, on craniosynostosis, that began due to a family of a patient with surgeons from Brazil and from Boston Children's Hospital and from Necker Hospital in Paris. They came together to create a symposium which had speakers that were patient family, that were surgeons, that were doctors, multidisciplinary component of this disease, but also we brought in ministries of health of Brazil and vice president of Ecuador. So all of there together talking about a problem, creating awareness. And this was in national newsletters of Brazil, the biggest newsletters in Brazil. We published about it. We created awareness. We did proceedings of this. So it's how we can together create this awareness. These are other examples in which are recent publications from myself and my team, also trying to, in different scenarios, create awareness to what are we talking, right? Focusing out what are the problems and how we can gap these problems into solutions. So these are a few examples. This was in the United Nations General Assembly in UNGA, where we mentioned that, okay, we're talking a lot about problems, but we're not talking about surgery, which should be a component of universal health coverage. So it's also like being timely on calling out for specific problems when we have clarity of them. This was another example after we worked on the Ecuador NSOPs, in which we started promoting not only into the national level, but how we could extend this regionally. And it took to the PAHO, to Pan America Health Organization, to, on their national directive committee, to their directive committees, to understand and recognize surgery as a component and should be included in their agenda as a priority. So these are huge things that came from this integration of research, advocacy, and policy. And leads me to policy. So I mentioned about the NSOPs. For those who might not be familiarized, these are the National Surgical Obstetric and Anesthesia Plans, which are plans in which we can start trying to multi-collaboratively, how can I say this, but in a way that we involved, again, academia, governments, clinicians, patients. We can do it in a way that is nationally, but also with collaborators, international collaborators. And we come together to create these plans in which we identify the gaps of a specific country. And we, based on these gaps that were identified, we proposed a plan to try to solve each and one of them on a set time of a goal. And I was really honored to be part of the Ecuador NSOPs, in which we were able to not only identify a few of the gaps that were already there, but also try to understand which could be implementation projects that could be integrated into these plans to solve the identified problems that we solve. And a few of these integration plans that we saw, one of was maternal health. The other is in child health, and which is promoting workforce training. And another main innovation of this NSOPs, innovative feature of this NSOPs, would also understanding climate change as a pressing problem and how we could integrate a climate change into national surgical plans in a way that is not only on mitigation, but also an adaptation. And since this plan came out, it's still currently, due to government and political administrations, trying to be integrated into the country. But even before its integration and implementation, already things started to being planned and solved into it. And also in a regional perspective, it has fomented urgency and an awareness in the region, in which other countries started showing interest as well to have their own national surgical plans in practice. And this is how it has evolved in the past years, and it continued evolving, and hopefully it will continue, because again, when we talk about global surgery, it's not just going there and trying to sugarcoat the problem, but also trying to understand how we can really create the solution from the ground, locally led, and in a sustainable way that will continue through the years in a way that it's organic, but it's also sustainable. And here we talk, I'm going to transition into another component of when we talk about pediatric global surgery and how academia and academic pediatric global surgery can be involved. And one of also the things that I have been really passionate about and involved from the start. So this is the first one I'm going to talk about is the TRIC course. Workforce is a big gap in global when we talk about global surgery, and specialized also workforce is another problem. And when we talk about pediatric trauma and pediatric global surgery, there are really few courses that are directed for pediatric trauma. We have courses that are focused on trauma, but we still lack a lot on how to train pediatric trauma, for example. And the TRIC course is a course that it's come from Canada, and it has been perpetuated in many places in the world. But the idea here was one of my mentors and dear friend now, Dr. Botelho, he, from his master's and then his PhD, he saw this gap on workforce training. And he had the idea with our supervisor, Dr. Den Puenaro, and the team of TRIC course, of course, and the directors of TRIC, to take these courses to many LMICs. And one of them was Brazil, in which I had the opportunity to collaborate with them and help on integrating this course into Brazil. And now GTRIC is now expanding to many other countries. And innovation. This is I want to stop in innovation, because many times when we think LMICs and when we think global surgery, we stop in the part of innovation, but innovation comes in really shapes and forms and ways. It can be simple, it can be complex, but we shouldn't be stopped by it due to fear of innovating and also bringing technological solutions, because sometimes we bring innovation in a standpoint that is not technological. It's more the innovative perspective of a new idea. But when we talk about technologies, it's something that is evolving worldwide, and we shouldn't be stopped by it. And we should think how we can take also this into our practices. And this was another opportunity that I have been proudly been part of collaborating with our dear collaborator here from also Jamaat Al-Abesh Pediatric Fellow, Srini Kundu, who he, as part of his PhD, and with Dr. Botelho and Dr. Den Puenaro, they're expanding on the PTVR, which is trying to create workforce training through innovative solutions, which in this case is through VR headsets. And one of the pushbacks that they have been having in a few places is how can we take these innovations, how we can integrate this into global surgery? And I see that as opposite. How can't we, right? When we're talking about giving equitable opportunities and we're trying to create solutions, we have to be innovative and we have to talk about technology. So this was part of his PhD. We went to India and we ran the course there. And I would say the Wi-Fi connection, I don't know, I know this is being recorded, but the Wi-Fi connection was better there in India than many times here in Canada, McGill. So what I'm saying is sometimes people are afraid of taking technologies, and India is a huge country with many technologies. Most of our technologies come from India, and they have the potential to have these innovations. And they would share with us that many times they would get a paper VR headsets instead of technological ones. And why? So, but this also comes from understanding local perspective, collaborating locally, and understanding context-specific scenarios, but most of all being something that is co-designed and co-led with local leaders, and potentializing these leaders so we can create solutions that can actually be good and can actually be sustainable. And And this is how realistic the VR headset is amazing. So lastly, I am taking all these values I have learned through these almost 5-6 years in academic pediatric global surgery, now here in my PhD in Canada under Dr. Poinar's supervision, in which we're trying to understand even more what are the gaps in access and outcomes in pediatric global surgery. So again, taking the component of research, how we can do this co-design and co-led with local leaders, and how this can be translated into policy and advocacy, into implementation and innovation for sustainable changes. So these are a few of my experiences. I don't have much time to share everything I would like. I want to pass it to Dunya so she also has the time to share her amazing journey. But it's just trying to say how much we can do from our own settings, and how collaborating and working together, we can understand the current scenarios we are in, that sometimes we know that they're there because we do complain sometimes about the problems that our patients are facing or we are facing in our settings. But we sometimes lack on stretching that hand on what is that I can do to change this, and going there and working together to create this change. So if I can leave something today, would be this, like, how can we get out of this box, and through academia, through our clinical knowledge, through our collaborators, we can come together to create solutions locally and globally. And now I'm going to pass it to Dunya.
Thank you so much, Ayla, and thank you for the opportunity. I'm very glad to share my experience, that how I became involved in global surgery. Next slide, please. As mentioned at the beginning, I'm a pediatric surgeon from Afghanistan. So if I were to give you a brief snapshot of pediatric surgery in Afghanistan, so the country has a population of 40 million, and nearly 50% of those population is under the age of 15, making it a very young population. And due to decades of continuous war and the recent changes that happened in 2021, now around 70% of the population lacks access to affordable health care. Next slide, please. There is no official recent data available, but in 2019, we had around 140 pediatric surgeons in Afghanistan, and only 4 of them were women, including myself. So this translates to approximately 7 to 9 pediatric surgeons per 1 million children. And after the government change in 2021, a mass migration occurred, and which many pediatric surgeons, fearing for their safety, were forced to leave their country, including myself. Next slide, please. There are only 5 facilities dedicated to pediatric surgical care, and all of them are located in Kabul, the capital. Recently, some private centers have begun opening in other provinces, which has a department or a part for pediatric surgery. But unfortunately, neonatal ICU services, pediatric anesthesiologists, and pediatric equipment remain in the short supply throughout the country. And once a patient is trying to get or receive a pediatric surgical care, unfortunately, due to a lack of information, they cross multiple steps. That first they go to traditional medicine, then they go to a general surgeon, and then they come to pediatric surgeon, which creates a delay to pediatric surgical care in the country. Next slide, please. So as I mentioned, Afghanistan went through a major political change in 15th August 2021, when the US troops withdrew and Taliban took over the country. So next slide, please. Before this government change happened in 2021, I attended the Pacific Association of Pediatric Surgeons annual meeting in New Zealand in 2021 as a GAP Alliance fellow there, and I got introduced to the two amazing pediatric surgeons, which are very active in global pediatric surgery. And I'm sure you are familiar with their faces too, Dr. Butler and Dr. Emil. So I had the opportunity to follow their work through years, but when this political change in August 2021 happened, they were the first people to reach out and make sure that I leave Afghanistan safely. So now that I'm working with Dr. Emil and Dr. Panero in the Montreal Children's Hospital, I'm very happy to be working with them. But I want to mention, and I want you to note that working like through this connections that we create in global pediatric surgery or in these global surgery network, sometimes they actually save life of the healthcare workers too, not just the patients. And if you're interested to know more about this journey, which it was another story, which a bit difficult, it's published in the GPS and can be accessed there. Next slide, please. So after leaving Afghanistan, I felt this deep emptiness that back home I was able to help children every day, but suddenly I couldn't. Then I was introduced to Kids War, our Kids Operating Room, which is a global health charity transforming surgical care in underserved region. They built operating rooms, also support training for local healthcare workers, and collect local data to measure the impact of their operating rooms. Next slide, please. So up to now, they have built around 95 operating rooms in 34 countries. Recently, they start their work in Europe too, that they are, each year, they are enabling around 200,000 operations. And what's unique about their project and their working process is not just building the operating room and leaving it to the locals, but they have this continuous support for a period of 3 years after building those operating rooms. And once they feel that this operating room can function independently, at the end of the 3rd year, then they will decide to continue their support or not continue the support, which made it interesting for me. So we begin, next slide, please. Thank you, Ayla. So we began working on the Afghanistan project at the start of 2021 and had a fully functional operating room by early 2022. We chose the country's 2nd largest governmental children's hospital, which is named Ataturk National Hospital, because this hospital serves the indigent patient with no health insurance. Also, they have the patient load around 1,300 to 1,500 elective and emergency cases in 1 year. The team at that moment consisted of 4 pediatric surgeons, 1 anesthesia specialist at that moment. Next slide, please. So in the first 9 months after this project started, around 1,000 patients were operated with good outcomes. And the important part was that waiting time for elective surgeries decreased from 6 months to 3 months, almost half. And with this project, we were able to create the first database, pediatric surgical care database in Afghanistan, to collect data for pediatric surgery. This was the first time. And also the results got published in the Journal of American College of Surgeons, which is the first study that gives us an idea of how the pediatric surgical care is in Afghanistan currently. And also it's important to note that this project happened during a time that Afghanistan was not safe for any of our team members, including myself, to travel and be able to manage the project. So, but still we were successfully able to manage the entire project through the dedication of local surgical team, because they were very interested to have this operating room, along with coordination only happening through Zoom and WhatsApps. Next slide, please. Currently, I'm working on another project, which is very close to my heart. And next slide, please, Ayla. Which we are studying the gender disparities in pediatric surgical care access. We designed the study in 3 phases. That in phase 0, we conducted a systematic review and meta-analysis. And in phase 1, we are gonna apply a mixed method study design to confirm our finding of systematic review, and then to better understand the perspective of families and healthcare workers on regarding the gender inequities. And in phase 2, we are gonna use experience-based co-design approach, in which then we will work with the families and healthcare workers to identify their service improvement priorities, and plus co-design tailored intervention to address them. This study is going to happen at the moment. We are planning to conduct this study in India and in Pakistan with the help of local team under supervision of Dr. Panero, of course. Next slide, please. So in phase 0 that we conducted our systematic review, we out of 8,000 paper, we included 99 studies in our and a final analysis. Next slide, please. The majority of our studies were coming from India, Pakistan, and Turkey. That's why we choose the India, Pakistan, the 2 majority sites to conduct the rest of the study there. And it has around, it covered around 10,000 patients, and the male to female ratio was 1.7 to 1. Next slide, please. And yes, next. So in the meta-analysis, we find out that boys are 2.5 more times more likely to receive surgical care than girls, which is an alarming point to notice. But we are planning to, with the rest of our study within the next steps, to confirm these findings and then look out the contributing factors. Next, please. Because we are acknowledging that pediatric surgical pathologies are not happening into 1-to-1 ratio, we went a step ahead of our meta-analysis and compared it with the international global data, that whether this our findings are matching the global data or not, which we still saw that there is a disparity exists. That's why we are so sure and so interested to go to the next step, then phase 1, and confirm these findings, and then learn about contributing factors to these findings. Next slide, please. So to conclude, academic pediatric global surgery plays a vital role in reducing preventable childhood illness and disability through evidence-based research. This work strengthens health system by guiding workforce planning, service delivery models, and quality of care improvement. We also have an ethical responsibility to ensure that our efforts are relevant, sustainable, and locally led. When research is informed by local priorities and paired with policy engagement, it leads to real, measurable improvements in surgical access and outcome for children. Thank you so much.
Thank you both very much. I think these talks also are wide-opening in many ways. It shows us what can be done and what can be achieved. Just looking at the chat at the moment, I can't see any questions, but could I ask a question to both our speakers? Is it difficult to overcome the obstacles with the international health systems the local country's health system allowing, these type of help arriving, being, the studies being conducting. How do you overcome those obstacles? Because I think that's probably one of the most difficult parts, the uh, the red tape part. Would you like to comment on that?
Sure. Do you want to start, Dunya, or you want me to go first?
Go first, please.
Okay, perfect. Yeah, I think that's a great point, and we should discuss it. I feel that's why we should start mainly emphasizing by collaboration and co-design with local leaders and the empowerment of these leaders. Because when we have these conversations, then we can contextualize to that setting and understand where this resistance and push-off is coming from. Is it the government side? Is it the patient side? Is it from the practitioner side? So I think once we have first an understanding of the context, of the local context, but most of all, the empowerment and collaboration with those local leaders, and understanding if we are needed when we do these type of research, if they want this type of research, if why are we doing this, right? So I think when these conversations happens, then we can also understand how to address them. Is it due to patient hesitancy because we're coming from a different context? Then it's also having these local leaders there to understand how we can close these gaps, or they don't want us to be there. Like, how can we solve this? If it's a government, also how we can have the communications and dialogue, and the resistance and pushback won't happen if there is leaders there empowered to guide us and go with us. And I think it's also taking off that concept that anyone needs help from anyone. It's more like something that has been done together, is not something that when I'm doing work in Brazil, it's more, how can I work together? How can I use my time and a bit of the experience I can to help design this project? And most of all, what I can learn from this. So it's mostly about how we can collaborate together. And I think this is something that global surgery has evolved to, on something that is this empowerment of local leaders, and it should always be like such. I don't know if that completely answers your question, but I would go more towards that. Yes.
So it's mostly local leaders, from what I understand. So are these local leaders collaborators usually from the medical field, or is it the administrative people? Which ones do you approach first?
Yeah, it depends also what we're talking here. If we're talking more on the academic perspective and the research perspective, if we're talking more on the clinical perspective, if we're talking more on the government perspective and policy making. For example, the Ecuador and soaps, which is an example I can give. When it comes to policy initiatives, usually it should come from the government itself, and we shouldn't be there to say anyone what to do. It's more a consultancy on how these plans can be designed, but everything should be done by those who are in the ground and who understand their country. And in this case was the vice president of Ecuador, who showed interest in having an NSOAP in their country. So it came from them asking, how can we do this together? When it comes from academia, it could be through collaboration with surgeons there, or practitioners there, medical students there, or even the same universities and institutions. So I think it depends also on what we're talking, and then how this integration can be made. Because once you have these connections, then the possibilities flow more organically, let's say. These are most of the perspectives I have from the policy perspective, the academic perspective. I don't have any clinical perspective on going to a country and creating connections there, or doing any type of missions or surgical practices. So I couldn't speak from that end. But I don't know if Dunya wants to share a bit more on the clinical side from being there, on how this works.
Yeah, Dunya, it seems that from what you presented, it was a big project. You talked about many patients, many physicians being involved. Do you want to comment?
Yes, sure. On what Ayla mentioned is that although this project was a unique project because it happened in a time of instability, but also that gives it a power that even when there is political instability in a country, at the end of the day, everyone needs healthcare. And even like at that point of there, that the current government of Afghanistan was in a point that the exchange of power happened, and they were getting used to the work and what is happening and getting familiarized with the work. Was happening, we were able to connect the surgical team on the ground. The first point of contact was them, and just talking with them that this is the vision that we have, what do you think? And I can say that the rest, the majority of the work was done by them, by the head of department, by the surgical team, that they went to the hospital and then they went to Ministry of Public Health, and they made it possible. Like, yes, we need this care, and this, we know the intention, and it's a good care that, or it's a good initiative that we need in our hospital. So we need it, and that insistence created this project, and we were able to go ahead with it. So involving the local team and the project being locally lead will help us a lot, because they know they have their connections on the ground better than us. The first point, and the second, that they are able to understand the culture sensitivity, a part of our initiative, the part that we can get pushbacks, and they can come up with their own solution, which is appropriate. We might come with a solution which is not appropriate at that situation, but the local team knows better. Based on my experience that I had with this project, and now that with the second project that we are working with India and Pakistan, they come up with some suggestions and ideas. Even now that it's just the basic phase, we are involving them, because they are coming with some points or some suggestions that are very culturally sensitive, and they know better than us. So that's the point with the work, and every work that we do in the lab, that we are trying our best to include the local team even in the basic phases of planning our projects.
Thank you. Now, I'm glad we are getting some questions, and actually Dr. Mohit Kakar, who is one of our Global Pediatric Surgery Initiative participants, he wants to, I think he has a question, so I just turned on the microphone for him. Mohit?
Yeah.
Okay,
Hi,
thank you.
hi, Alia, and hi, Dunya. Thank you very much for your wonderful presentation. I just have a small thing. I see that maximum of your projects are based in India and Pakistan. Is there a simple reason behind that you get the ethical approval or the permission from the committees or the local organizers very easily, or it's because the population is more, so that you get more patients involved in the projects? What could be the reason?
For my project, if I want to answer this question, first of all, thank you so much for this question. First of all, coming from Afghanistan, I was very interested to this project to be in Afghanistan, but unfortunately that I cannot do that. The closest that we can go is South Asia, and we choose India and Pakistan slowly. Based on that, in our systematic review, we find out that the majority of papers are coming from India and Pakistan. So that gives us a recruiting point, that because first of all, the research culture is so common or so advanced in India and Pakistan compared to other countries in the region. So that was the point that for my project, we choose India and Pakistan. And then again, based on the collaborations that we already had existent, we tried to perform this project in India and Pakistan. Not any other reason for my project.
Thank you. Thank you for your answer.
Thank you, Dunya and Ayla, and I thank you for your presentations. Very inspiring. I think we have two questions that have opened up here. We have a question from Seneb Merve, GOG budget. I think it's for Dunya primarily. Thank you for the insightful presentation. I was wondering whether you have any plans to expand your team in the future globally. Do you have any comments on that?
And do you want to go ahead, Ayla?
Yeah, I think I'll attach both questions and then I can go from there. So my work mainly, I have been focusing a lot in Brazil, and we have been expanding it to, I have been expanding at least my projects into PAHO, which is where I have a better understanding of the local context and the collaborations are there. And then through the program in global surgery and social change, each team has their kind of collaborators and countries and contexts already settled, which makes possible to continue doing projects. And if the opportunity presents, for example, in Ecuador, that the vice president expressed interest, we started doing projects there that went beyond the NSOAPs, and we continue doing academically. And then now, as a JML fellow in McGill, our lab, Dr. Pornaro has been always offering opportunities and JML fellowship as well for people all over the world to come, maybe as a PhD, and do projects in their context or in collaboration with different countries. So I feel the expansion, at least in the settings I have been in, the teams I have been, are always motivated by personal passion or even by collaborations that are already settled. And then the opportunity comes to be expanded nationally, regionally, or even globally as other opportunities occur or other people express interest and other connections start occurring. So I feel, yeah, that would be my answer. There's always an interest on expanding and collaborating, but always, again, carefully on how it's done.
The second question is from Dr. Yahya Mohammed, and he says he's from Nigeria and is passionate to specialize in pediatric surgery. He's asking if there are any global opportunity fellowships to apply for, as I just finished my internship. So I think if it's pediatric surgery concerned, I can give an answer here. Some countries accept overseas, fellows for training. And I know in the country I practice, which is Turkey, you just take an exam. First of all, just that you're qualified according to the national, board, and then you can enter, as we have overseas trainees. And I'm sure there are multiple, opportunities there. So please just look into that, because that's the and if it's global opportunity in terms of global pediatric surgery, then I think what Dr. Ayla and Dr. Dunya are doing is they're focusing more on the not pediatric surgery itself, but healthcare policies and other things. So again, that's an area which you can look into. I don't know if anybody would like to add on to that. Dunya, you trained in Afghanistan, now you're practicing, you're now doing your PhD in Canada. Any suggestions?
Yes. So in terms of the question to if this doctor is interested to do a pediatric surgery specialization, so every country has their own licensing procedure. That first you go through the exams, and then I'm sure in Nigeria, as I know, is the same, that you first do a surgical specialization, and then after that you go to a pediatric surgery fellowship. That's how, if you want to be a clinical pediatric surgeon in any country, even if you want to migrate from the US to Canada or Canada to US, which are very close to each other, again, they have their credentialing system. It's not just we can practice. Me coming from Afghanistan, our system was different, that we had directly, you would be able to do a 5-year pediatric surgery specialization, but in other countries it's different. So every country is different. But if this doctor, our doctor, is interested to do a fellowship in pediatric global surgery, then there are opportunities that Ayla was kind enough to create this slide and share that which opportunities are available. That you can see here that at the top at McGill is the fellowship that we both are doing at the moment, which is in global pediatric surgery. But there are other opportunities too that I'm sure Ayla can explain it better than me, but there are opportunities for global fellowships available too. Which I want to mention is some has a clinical part, some doesn't, it's only research.
Thank you both again for this detailed answer. And Merve just thanks you both again. She says the topic is quite new to me, and I'm really happy I had a chance to listen. And she says she believes that this should be shared with many more people. So it will be on our YouTube channel, and we hope people will come and watch this really very informative and exciting webinar. I think I would like to give the word now to Judith Stolz, because she did the introduction. I think she should wrap it up, and because she is also especially invested in this topic. So Judith, it's now, please, your turn.
Yeah, thank you very much to everyone. And I really enjoyed just sitting back and listening to you and your experiences. And I think it's also about exchanging experiences and creating a network and a community. So I hope to get together in the future. Maybe next year's conference, the EUPSA conference in Vienna, will be a good chance. Yeah, I hope that you have surely touched my heart and inspired me, and that this has been the case with everyone who will listen in the future and who has listened today. So thank you very much.
Thank you so much for the opportunity.
Thank you so much. Just double checking. Yes, Anna, also my co-chair, says thanks for the great talks. She had to leave because she had some hospital, I think, work to attend to. Udo, would you like to comment anything at the closure?
No, it was perfect. Thank you very much, Aya and Dunya, for these wonderful presentations and for the leadership of Judith and Gonca.
Thank you. Thank you very much. Okay, then Ayla, Dunya, Judith, everyone who's online still, thank you very much for the attendance and also the contributions. We hope that this will be an inspiration to all, and global pediatric surgery will be thriving in the coming years. Thank you. I would like to end this session now. Thank you very much.
Everyone.
Thank you.
Thank you.
Bye.
Goodbye.
Goodbye,
Bye.
everyone. Thank you.